which I think will be really helpful for us when we talk about our patients. So very first thing we always have to do is talk about shock, right? And I sent the PDF, so hopefully everybody's going to get a PDF. Angela, I'm sorry. Will everybody get a PDF? Because I sent the PDFs.
Yes, we will upload that.
Everybody will get a PDF,
We
so don't
can
worry.
upload that to the website.
Yeah, so don't worry, you'll get, whatever's on the slide, you'll get. What I say, you won't get, because they might not match, but that's okay. So, when we just talk about shock, it's always important to remember that the underscoring mechanism of shock, no matter what the cause is, it could be traumatic, hemorrhagic, hypovolemic, sepsis, distributive shock, dissociative shock, or cardiogenic shock. The underlying issue is inadequate perfusion of the tissue level. And so that's always where we begin, that's where we end when we talk about shock, is how do we actually maintain perfusion and adequate oxygenation at the cellular level? And that's a really big statement, but it's quite simple. When you have a patient with metabolic acidosis, and they meet some of the other criteria, you should always assume that's shock until proven otherwise. So what really happens when we talk about this issue of hypoperfusion or reduction in blood flow at the distal tissues? So by the way, when you put a pulse oximetry probe on one finger, you don't get a pulsatile signal and therefore no SAC reading, and you put it on the other hand, you still don't get it. Guess what? Your patient is vasoconstricted and they don't have adequate blood flow. So you spend 15, 20 minutes, you get 7 probes, your preceptor, your charge nurse, the doctor in the room, I can't get it, something's wrong with this equipment. No, something's wrong with the patient. And it's a really good sign that you have somebody who's in shock. But it's a really important concept. When we don't have adequate blood flow, you're going to shift to an inefficient form of metabolism. That inefficient form of metabolism causes metabolic dysfunction. That metabolic dysfunction is the failure of neutralizing lactate. So lactate goes up, and in addition to that, your patient is donating metabolic acid into the blood. That metabolic acid is hydrogen ion. You don't measure it, but you look at it as an opposer. The opposer to hydrogen ion, in the most general sense, will be bicarbonate, or can also be evaluated by a base deficit. So that is a really important concept. As we go on in evolution of understanding shock and looking at criteria, actually we all can say, yeah, we know, we look at lactate for sepsis. Oh no, lactate for cardiogenic shock is a really important clue, but you never look at lactate without looking at the component of acidosis. Either what's recommended is the base deficit, but if you don't have, your blood gas doesn't give you a base deficit, even your venous blood gas doesn't have to be arterial, you don't get a base deficit, then just use bicarb. Bicarb down, base and deficit. Hold down, metabolic acid is up. That's going to be a really important clue for us, because we want to intervene before you end up with destruction of the lining of your capillary, which then promotes edema formation and very profound alteration at the cellular level. So that's a really, really, really important thing. One of the most important criteria is serialization. Okay, I'm not talking about Raisin Bran. Serialization of lactate. That means you have one lactate that's normal, but your patient looks abnormal, you need to draw another lactate. And you should do that every 2 to 4 hours. And if your budget doesn't allow every 2 hours, every 4 hours is okay, you're going to follow the track, right? Everybody's budget's a little bit hurting right now. I work at a safety net hospital in Atlanta, Georgia, 1,000-bed hospital, Grady Hospital. We're a publicly funded safety net hospital, and we're hurting right now. Our budget's been cut a lot. And my hospital is trying to maintain staff, but they're reducing budget everywhere else. So it's amazing to me they haven't actually looked at the fact that we order complete lab profiles on every patient every 2 hours, because we have 2 medical schools and a lot of variability. They don't say, stop ordering all those labs, which would be really great, because we should only be getting what we need, right? We definitely need to follow serial lactate. That's going to help you a lot when you're evaluating and staging shock, because again, whatever the cause is, if you have inadequate perfusion you are eventually going to upload volume into the cell, have cell rupture, have destruction of the lining of your blood vessels, that's called the glycocalyx. And eventually that fluid, all the fluid you give, ends up in the interstitium, which then causes a basic compartment syndrome to every single site in the human body. And you're not doing fasciotomies for this, you're basically saying, oh my gosh, you're not making any urine, and he's hypotensive, let me give some more fluid, maybe now I'm gonna add a vasopressor, both of which may actually be problematic. And definitely, if the cause of shock is cardiogenic, vasopressors and fluid can be very problematic. So, we really want to recognize this continuum of dysfunction that presents with anaerobic metabolism. So whenever we think about cardiogenic shock means that you can point to the fact that you do not have an adequate ventricular ejection. Okay, that's really cardiogenic shock. And instead of saying you have to memorize it might be a dysrhythmia or you had an MI or this or that, by the way, you're putting yourself on a trajectory that limits your potential of understanding. Cardiogenic shock means that your cardiac structure cannot enable an appropriate stroke volume, the amount of volume ejected by the heart with each beat, and therefore cardiac output. Okay. Now, I want to make sure that we appreciate that cardiogenic shock does not require that you had an MI. Cardiogenic shock occurs in about 50% of septic patients. They have septic shock and cardiogenic shock. That's called mixed shock. And I've been saying, really probably for 20 years, people don't die. Generally, people don't die from their infection. They die because they have cardiac failure. And so, in my hospital, here's one place where they talk about the budget. My hospital, you got an echo, you're not getting another one. What? Wait a minute. So my guy came in, we diagnosed him as having septic shock. We just took a quick look at him with an echo and we saw that he had an EF of 60%. And then 3 days later, he has refractory hypotension, he has an elevated CEP. I can't resuscitate him, he needs another echo. And when we do get another echo, we frequently see you now have an EF of 15%. Came in with 65 and now you're 15. And that's with sepsis. But now it's not just sepsis, it's mixed. And it's cardiogenic shock combined with sepsis. This is critically and profoundly important. Now, typically when we think about cardiogenic shock, we think about the first presentation, patients in the emergency room where they've been admitted to the hospital. It is true that it is related to MI, that it's related to myocardial ischemia, that could be related to dysrhythmia or congenital disorders or valvular disorders. But if you look at your patient that narrowly, you're gonna miss the boat. You have to have a really broad view here. If I give you volume and you have a good heart, your heart should eject that volume. Okay, that's pretty straightforward, right? If I'm giving you volume and your central venous pressure is going up, your neck veins are distended, you have interstitial edema, but you still have hypotension, you got a problem with your heart. And you can call it sepsis all day long, but you're missing the point. If you have an adequate system, any volume I give into your veins should be ejected into your arteries. If that is a failure, you now have basic cardiogenic shock. It might not meet all the criteria. People may look at you like you have 4 eyeballs. It's okay, because you're there to advocate for your patient. So really, really, really important in whatever way you're going to look at your patient. So if you're lucky enough to have an A-line, you're looking at LV ejection, that would be from your A-line, maybe from your pulse pressure, which is actually part of the 2025 recommendations to just say pulse pressure, which is systole minus diastole. Or you have the ability to look at converted stroke volume from your A-line, or you have other methodologies that look at left ventricular ejection. So remember, the PA catheter is a right heart catheter, it's not a left heart catheter. You have to look at left ventricular ejection here when you're talking about cardiogenic shock. If you can actually say the volume I gave the patient doesn't end up in the arteries, my patient's his urine output has gone down, he has refractory hypotension, he has worsening acidosis because your bicarb keeps dropping, you have a worsening base deficit, your lactate is elevating, your patient's in shock. And if they cannot move volume from the vein to the artery, that is cardiogenic shock. It could be right side of shock, it could be left side of shock, it could be biventricular shock. But when you are seeing that, which you see all the time, but no one is saying, there's a cardiac problem here. We just keep giving volume and we say, oh, he's got sepsis, go up on the norepi, go up on the epi, add vasopressin, maybe he gave angiotensin, whatever. And we're still venal volume overloaded and arterially volume underloaded, which means there's a problem in the relay of that volume. And that's what defines cardiogenic shock. So one of the really important perspectives, beautiful, just the way everyone, and I have my reference list at the end, so just talking about myocardial dysfunction or myocardial infarction, either one. When you have failure to eject, you will ultimately have failure to fill. That's because if you cannot appropriately eject volume, the ventricle is going to become basically distended and no longer able to accept volume effectively from the atria. So you start with systolic failure and you end up with diastolic failure. So the easiest way to always remember, systolic failure is about failure to eject, diastolic failure is about failure to fill. So when you look at an echo report and they talk about a patient has primary diastolic dysfunction, that's a failure to fill, primary systolic dysfunction, that's a failure to eject. But failure on one will always ultimately cause failure on the second. So you might, in the beginning, have a stiff ventricle, you have failure to fill, but eventually that's going to affect ejection, okay? So really, really important for us to remember that. I'm in love with the PA catheter, but I'm in love with the PA catheter for right heart failure. I don't need that for left heart failure. I look at the arterial perfusion for left heart failure, and it could also be secondarily right heart failure. I mean, that's a whole nother bag of worms. But when we look at this, you see, okay, with systolic failure, number one thing that happens with systolic failure is a reduction in cardiac output. Okay, you're not measuring cardiac output. Okay, a reduction in stroke volume. Okay, you're not measuring stroke volume. Okay, a reduction in systolic pressure. In other words, failure of ejection. Systolic pressure represents failure of ejection. That, I can't make that any more basic. And that means when I give you volume, I expect systolic pressure to go up. When I give you an inotrope, I expect your systolic pressure to go up. And when I give you a vasopressor, I'm praying that your systolic pressure doesn't drop. Because if your systolic pressure drops on vasopressors, you have now put a burden on the heart and you might be causing cardiogenic shock. Systolic pressure responds to volume and inotrope, and you want to be sure that you don't diminish the systolic pressure with your vasopressors. Okay? That's a really important perspective. Now, when that systolic pressure drops, obviously diastolic pressure will also drop, and your patient will now have hypotension. And the biggest concern we have here, in any form of shock that patients present with that you're evaluating, any form, is a reduction in coronary artery perfusion pressure. So, coronary artery perfusion pressure in a person who is normotensive at 80, 120 over 80, not somebody who shifted to the left or to the right, just thinking about what your normal pressures are and how you accommodate to that. If your diastolic pressure drops below 55, you are going to have a significant reduction in coronary artery perfusion. And that is a critically and profoundly important point. So when I'm evaluating patients and I'm thinking about what I need to do for them, I must admit, in my current iteration of who I am clinically, compared to where I was 15 years ago, 15 years ago I was like, yeah, vasopressors are the enemy. I still think they are. I think they're the enemy because we're really cavalier about them and we don't really look at what we're doing. But I definitely need to get your diastolic pressure up to maintain coronary perfusion. Now that's really important because vasopressors are what bring up your diastolic pressure. Right? Fluid inotropes help bring up systolic pressure. Vasopressors bring up your diastolic. Okay. Well, if I have a reduced coronary perfusion, then I'm going to have ischemia, which is then going to progress to more myocardial dysfunction, whether or not, right? Whether or not I have coronary artery disease. Remember, there are multiple types of myocardial ischemia. Some are correlated, type A, correlated to coronary artery disease, but B is related to oxygen supply and demand. So as I'm using a vasopressor, especially if I'm using epinephrine, I want to be balancing in my mind that epinephrine is going to increase myocardial oxygen demand very significantly and can actually put my myocardium at risk, even though it happens to be the drug of choice for all CT surgeons. I don't know why they love it so much, but it's okay. It also can promote a sympathetic overload that can cause persistent, which means either recurrent or refractory ventricular tachycardia. So by the way, when you're coding a patient and they have VTAC, and you put them on norepinephrine, you add epinephrine because you're trying to get their pressure up, you shock, you gave amiodarone, and the patient continues to go back and forth into VTAC. One of the most important things to think about is sympathetic overload. Number one, add a beta blocker. For us, it's esmolol because it's brief, and it should be something that we're thinking about early on in our algorithm of recurrent VTAC. And secondly, it may be beneficial for you to turn off the epinephrine. If you need something else for a vasopressor, you might need a pure alpha. Unfortunately, I hate this one, but venous epinephrine. If you are on epinephrine titrating upwards in a person who has recurrent VTAC, who is in now cardiogenic shock, epinephrine can make that situation much worse. So we always want to have a discussion about this when we're managing patients at the bedside. Okay, so of course we understand that now you have compensatory vasoconstriction, you have inflammatory mediation, you have systemic hypoperfusion that just continues in this cycle towards death, and that's what happens, right? The other issue is, of course, diastolic dysfunction. Diastolic dysfunction means failure to fill. Now, if I am looking at a chest X-ray, listening to breath sounds, looking at your saturation, and I see saturation is down, breath sounds have worsened, I have diffuse infiltrates on the chest X-ray, or if I have a PA catheter, I might look at your PA diastolic pressure, because probably you don't do a wedge when you have a PA catheter. I'm going to say, oh, your LVEDP is up. Most of the time, though, this is just, we're just making good critical clinical evaluations. That is, the lungs are wet, and or the neck veins are distended, and if the neck veins are distended, you have bilateral edema and interstitial fluid forms. Okay. Now, I'm going to mention this here because I could talk for the whole day, like just on this topic, and you can see what I was saying is I'm not really talking to the slide, I'm talking about the reality of our practice. I just want to remind you of something really, really important. As you start to see venous edema, so if you're looking at the neck vein, it's distended. If you're looking at CVP, it's elevated. That's venous edema. It's not hypervolemia. It's venous edema or venous stasis. And as you see venous stasis, what we know, kind of the endpoint of that may be, is that we end up with an AKI, we end up on CRRT or dialysis. But I want to make sure you appreciate, as you have venous stasis, that means your CVP is going up, your neck veins are distended. That is the single most important indicator of impending renal and liver dysfunction. We should be paying attention to this. And when I hook up every triple lumen, I'll make rounds in the morning, I'll say, that guy's got a triple lumen catheter, and here are what his problems are. We need to be monitoring CVP. Well, physicians didn't ask what the physicians asked for. You put that catheter in, it's mine now, and they don't pay for the transducer, nor the time that it takes me to zero level and And then when we communicate, we say, well, the CVP was 11 and now it's 18. And by the way, CVP was 11 and now it's 18 and the patient is hypotensive and I'm titrating up on his norepinephrine. This actually indicates I've got some cardiac failure. And they'll say, don't you know the CVP is a volume indicator? Oh yes, thank you so much. I'm so glad we agree. It is not a volume indicator. But what it is an indicator of is venous stasis. And volume shouldn't stay in the vein, it should move to the artery. So let's figure out why the volume's in the vein, not the artery. That's a really important concept, and it's a really good clue to cardiogenic shock. A really good clue, even though that patient didn't admit to your care or your unit with a diagnosis of cardiogenic shock. They were admitted because they had sepsis, but now they have mixed shock. 75% mortality because we don't recognize it and we don't treat it. Mayberry is very happy here.
I'm in love, yeah.
Well, I was either, she turned her friend and said, oh my God, she's so full of it. Or she looked really happy.
That's the opposite, ask them, yes.
She looked very happy, and you know what, I see all. Like, I'm a mom, I'm a grandma, I see everything. So be careful. Okay. So the other point of this, of course, is if it's actually coronary disease, we revascularize you. If it's not coronary disease, we actually have to support the heart. And most of the time, when we're doing heart support, that's going to be combinations of things like beta blockers, diuretics, inotropes, and we should be considering those things early on in this agenda and this perspective. So it is really important to remember that when we look at patients with shock, and that includes cardiogenic shock, the very first evaluation is what we hope for is that the patient is compensating. So typically, the way I'm going to remind you about compensation here is on any patient, persistent tachycardia needs to be investigated as a compensatory mechanism. As the heart rate goes up, you actually improve cardiac output. But the problem is, as heart rate goes up, you actually promote diastolic dysfunction. Why is that? Because your ventricle fills on diastole, but when the heart is beating really fast, you have less diastolic time. And because you have less time in diastole, you have some failure to fill. So it begins as a compensatory response, but it will quickly become decompensatory. And the other perspective is, as long as you are able to maintain your vascular tone, which you might not be able to do if you have a severed spinal cord, you may not be able to do because of the junction of inflammatory mediators and oxyradicals that promote vasodilation. But as long as you are able to, you will have peripheral vasoconstriction, which is why one of the very first signs and clues, and a very simple one, is pulse ox probe on the right, this is my right. Pulse ox probe on the right, pulse ox probe on the left. Call on my friends, get another probe, let's add another one, your patient's got 4 probes, 2 on each hand, and now you put one on the forehead and you're not getting a signal, right? Your patient's already told you what's happening. They are vasoconstricted. So really, really important for us to remember, back in the good old days we used to do a little nasal probe, now we use a nasal probe called the nasal alar. This is a preserved circulation to the nose. And that's why that can help you because the circulation to the nose, the alar system, the alar vessels, come off of the carotid arteries, and cerebral blood flow is preserved blood flow. So that's our last ditch effort, is actually look at the nasal alar and try to evaluate your patient's blood flow dynamics and their saturation. So very important here is you will have a decreased pulse pressure, systole minus diastole. Normally 30 to 40, you're going to have decreased pulse pressure with tachycardia. Tachycardia and a decreased pulse pressure is a sign of compensatory shock. And in this case, because we have a trajectory that's saying, is this cardiac? That's what we're going to rule out. You're going to have the same thing with actual pure hypovolemia, but typically with pure hypovolemia, you know that the skin turgor is poor, they don't have venous stasis of volume, right? They were at a football game or 4 football games in 104-degree temperature and they weren't drinking water, right? Whatever reason. Or they have diabetes insipidus or DKA or anything like that. But really, really important. Early on, you're going to have a small elevation in lactic acid. Okay. Lactic acidosis plus base deficit that is worsening is not typical of septic shock. It is typical of cardiogenic shock. So again, really evaluating patients. 1 lactate is never good enough. Always needs serialization. 1 base or bicarb is not good enough. Always needs serialization. If patients are not responding the way you think they should, right? So that's a really important perspective. Second level now is when your patient starts to decompensate. Now they are hypotensive. So hypotension, you are already in decompensated shock. Do not wait for patients to be hypotensive, ever. Now sometimes that's how they present to us, so we can't do anything about that. But waiting for hypotension is problematic. Now maybe you have methodologies for predictive methodologies for looking at hypotension. Certainly that's something that I think some of us probably here at Brookville that you utilize the predictive hypotension software. But for many of us, we don't have that. So it requires really good critical thought. But you need to pay really good attention to AI-mediated prediction of hypotension, looking at small changes that predict hypotension. By the time you have hypotension, you're already decompensated. Typically, when you have hypotension, you'll have some alteration in mental status because remember, cerebral blood flow is actually a preserved blood flow. But when you're in decompensation, shock, you're no longer preserving cerebral blood flow, and that's why we have mental status changes. You also have preserved blood flow to the myocardium, so you might also see in that state of decompensation that patient now has some dysrhythmias, but also they are now having ischemia of the myocardium, even if they didn't have a diagnosis of coronary disease. That's a really important, and that generally progresses pretty rapidly. We preserve our patients for some time because we're at the bedside titrating up on vasopressors and vasopressors. But I want to remind you that as you titrate up on vasopressors, you are going to be limiting cardiac ejection. And that's going to be a really important strategy when we're evaluating our patients. And of course, third stage is basically death. Irreversible organ damage and cardiac arrest. Okay, so if we just think about our classic measures of cardiac shock, I use this slide all the time to just say, as a bedside nurse, there are 4 questions I have to answer at the bedside. Number 1, do you have volume, yes or no, and where is it? Okay, so when I say volume, yes or no, where is it? I'm going to start first with, do you have volume, yes or no? I'm going to look at sodium. I'm going to look at osm, which is the content and concentration. I'm going to look at your beta-natriuretic peptide hormone, BNP. I'm going to look at your CBP, and I'm going to look at your weight. These are simple strategies to say, do you have volume, yes or no? Where is it? Okay. So if CBP is up, weight is up, you've got bilateral peripheral edema, you've got volume, but it's in the wrong compartment. Volume in the right compartment is measured by your systolic blood pressure, by your stroke volume, by your pulse pressure, by your EF, and by the way, by something really simple that I don't think anybody uses. It's really hard for me to talk about the heart without also talking about the kidney. GFR. GFR, glomerular filtration rate, like nobody pays attention to it. It's on your chemistry profile. It comes back when you've done a BNP. GFR tells you about the integrity of volume of the kidney. Now, if you've got CKD, that's not going to help. But you're a patient who's in shock, I'm going to look at your GFR. You come into my care, in the emergency room, I review all these cases of patients in shock. In the emergency room, they come in with GFRs of 15 or 20. Okay, so normal GFR, 80 to 120. If you are light skin, we're going to give a range of 60 to 120 if you are darker skin. Okay, so there is a difference, basically related to muscle integrity and muscle mass. So darker skin, gonna say 60 to 120. If you come in with the GFR 15, you are profoundly at risk for an AKI, and then I give you volume and your GFR goes up to 73. Okay, when I gave you volume, your GFR went up to 73, guess what? Your heart accepted the volume and ejected it. But I don't just stop there, I've got to figure out how I'm going to sustain that and make that better. Okay? So really, really important, GFR is a great indicator, it's a great value, it's very sensitive, it is not specific. It's very sensitive to whether or not you have arterial volume and appropriate kidney function. Very sensitive, but not specific. But it's a good tool, simple, for me to look at when I'm evaluating my patient. And of course, that ultimately correlates to urine output. The single most important parameter that we, as bedside nurses, can evaluate, and the one we fail at the most. Because, you know, we eyeball it, we dump it, we milk the tubes, we do all these things. Maybe we don't do it every hour, maybe we do it every 2 hours, whatever we're doing. It's the least well managed parameter with so much need. So that's something we can do. And then we go to whether or not the tissues are perfused. So of course, we already talked about base deficit lactate. If you have the capability to draw central venous gas from your central line, SCVO2, but actually really, really important with a venous blood gas sample is the presence or absence of oxygen in the venous blood. So normally, venous oxygen is 45 to 55. If you are less than 30, if the venous oxygen is less than 30, your patient has shock. And you use that venous oxygen, so you have no other way to look at cardiac output, you're going to use that venous oxygen to evaluate whether your resuscitation is appropriate or not. I gave you volume, I gave you blood, I gave you an inotrope. Your PVO2 should be coming up. If it's less than 30, that indicates your patient's in shock. So that's a really simple tool from the venous sample that you sent off. It'd be best if it was central, and you can only look at SVO2 from the central line. PVO2, though, you can broaden that out if you're drawing it from a peripheral thing. And then, of course, reminding ourselves about whether or not a patient is compensating. We're going to look at their heart rate. We're going to look at their respiratory rate. Respiratory rate is the most reliable sign in shock across the continuum of care. From neonate to the oldest of the old, respiratory rate is the most reliable indicator of compensatory mechanism in shock. Of course, your patient can't be sedated or paralyzed. They have to be able to breathe, right? And they have to be on, if they're intubated on a ventilator, they have to be on a ventilator methodology that allows them to initiate a breath. But a persistent tachypnea should always be assumed to be compensatory for metabolic acidosis to improvement otherwise. And then we're going to talk just very quickly about PbCO2. Venous carbon dioxide represents the anaerobic metabolism and the presentation of the respiratory acid, which is carbon dioxide. PbCO2, very simple, also around 45 to 55. If we compare PbCO2 to PaCO2, if I have a gap that's greater than 10, meaning my PbCO2 is up, but my arterial CO2 is not, you have to look at them together, and they need to be drawn at the same time. PbCO2 is up, PaCO2 is relatively normal, or it might be up, but the gap between them, so Pb minus A greater than 10, indicates inadequate perfusion. So when people say to me, well, we have no way to look at cardiac output, oh yes you do. Don't you tell me that. You can. It might be removed from an absolute cardiac output or an absolute stroke volume, but I'm looking at PbO2 down, PbCO2 up, PbCO2 minus PaCO2 wide, greater than 10, patient's got shock and they have inadequate perfusion. So now everything you want to do now is about restoring perfusion. And by the way, restoring blood pressure is not the same as restoring perfusion. So if I'm a bedside nurse going up, I'm norepinephrine and epinephrine, I want to look at, are things getting better or worse? And not just by whether or not I achieved an MEP of 65. Okay? Because that, again, that puts us on a trajectory and a pursuit that might actually be dangerous for our patients. So really important, sorry. So CVP and PAD indicates actually whether my ventricle can accept the volume that's been delivered to it. Preload was never meant, for us, preload pressure was never meant to be a volume indicator. It's about volume and stretch. When I'm overstretched, I can't stretch anymore, CVP goes up, PAD goes up, wedge pressure goes up. When my ventricle is stiff and it doesn't fill, CVP goes up, PAD goes up, wedge pressure goes up. It's pretty hard to create severe, profound hypervolemia in both the venous compartment and the arterial compartment. It's pretty hard. Most of the time, our hypervolemic state that occurs is venous hypervolemia and arterial hypovolemia. And that is the very definition. CVP up, systolic pressure down. That is the very definition of cardiogenic shock. And I don't care what the diagnosis was when you came to the hospital. It's the diagnosis now. And we have to investigate. And we have to treat to actually do right by our patients. So really critically important. So now I'm going to introduce the patient. I'm going to have to look a little bit because I can't remember everything about him. So this was a patient we had this year. 59-year-old male with a prior history of coronary disease. He had a STEMI and he had an LAD stent in the proximal LAD. He had 100% occlusion. His heart rate with reduced ejection fraction, that's the little r there, HF, heart failure with reduced ejection fraction. His ejection fraction historically about 35 to 40%, but today, when we evaluate it, it's now 25 to 30%. So pretty significant. Has hypertension, has diabetes type 2. He comes to the EMS because he has severe chest, calls the EMS. He's on 75, pulls off, calls the EMS because he has severe chest pain while he's driving. And it's just like the chest pain he's had before. And on evaluation, we see that he has an inferior MI, STEMI, and he goes emergently to the cath lab. So within 10 minutes of arrival to our emergency room, he's on the cath lab table. And they find that he has very significant distal occlusions of this OM 1, 2, and 3. So all of these are smaller vessels, but they are supplying this very significant inferior wall and most likely the posterior wall as well. So they do a balloon only. They don't place a stent, just a balloon only because it's too small for a stent because the vessels are really small. You can't really put a stent in them, and they were only able to dilate beyond 3, which is a little bit bigger. And then it comes to the CDIC for STEMI management. So this is his initial EKG, and everybody can look at this, whether you're great at EKG or not. You might say, oh, that might have a little bit of diagnostic uncertainty because the ST segment elevation, actually on his initial EKG, is not so profound. But of course, he does have ST segment elevation lead 2, lead 3, and AVF. Those are the inferior leads. I love to say 2, 3, and AVF are in a package, right? Because they all use the same positive electrode, 2, 3, and AVF. Lead 2, negative on the right arm, lead 3, negative on the left arm, and AVF, an assumed estimated negative vector in the center of the chest. But F, 2, 3, AVF, all use the same positive, and F is for inferior, okay? And so you see that, you also see that there's some reciprocal changes in the lateral leads, but what's also really important is that I have ST depression in what I would call my right-sided chest leads. And that's particularly V1, V2, and V3. You should never have ST segment depression in your chest leads. If you have ST depression in your chest leads, that typically indicates that it's the opposite of where your problem is. And your problem is ST elevation in the posterior surface. So he has a posterior, post-row inferior myocardial infarct, which means he is prone to cardiogenic shock, and it will most likely be right-sided failure cardiogenic shock because infraposterior affects the right ventricle even more than the left ventricle. So then we take a quick look at his labs. I don't know, I'm sure you're all doing HS troponin. I hope so. HS troponin is high sensitivity troponin. Can you give me a quick definition for high sensitivity troponin? Anybody who said, yeah, we do HS troponin, what's the definition? the normal. Are you doing HS troponin or are you doing standard troponin? HS? Everybody's doing HS? Fantastic. Good. And if you're not doing HS, you should be. Okay. Here's the thing. Don't get yourself all crazy. HS troponin is standard troponin times 1,000.
Okay.
That's all. In standard troponin, anything that was less than 0.04 wasn't evaluated. But HS troponin, because of the dilutant quality, actually allows us to evaluate under 0.04. So that means that I'm going to be able to see patients who are actually in acute process, probably early, as they are elevated. Normal HS troponin for men, 20. Normal HS troponin for women, 15. Okay, our patient comes in, first HS troponin 1,000, goes to 23,000, greater than 27, and ultimately starts to come down, then goes back up because he has a secondary issue. Okay, so you can see that troponin. Normally, we don't do quite so many troponins, but there were a lot of concerns about the patient. And you can see first, starts 7B is the CDICU, and Heart and Vascular Center, also CDICU or the cath lab. Then back to 7B, CDICU, then to a step down area, where he gets moved to another step down area, and by the way, comes back to the CDICU. Not just because of his troponin, but because of his clinical presentation and his evolving cardiogenic shock. So the other thing you can see here is his lactic acid is mildly elevated, 2.3, and then up to 2.4, and his BNP is mildly elevated, right? 181, I mean, for me, that's kind of mild because I have patients that are 2,200. So it's enough for us to say he's in heart failure. 181, 564, 531, and thinking about all of this and how this presents and how we carry that forward when we're thinking about what's occurring for our patient. He has other issues, liver enzyme changes and other issues. Okay, so first cardiac cath report on 6/1 was this basic, we basically did an angioplasty only, no stent placement, 013, couldn't do anything else, tried to actually improve blood flow, put him on antiplatelet agents and anticoagulation, and his LV EDP is 42. Now normal LV EDP is typically going to be less than 12. Okay, but he's 42, so he already has left ventricular dysfunction, a high degree of left ventricular diastolic failure. Okay, then he has an emergent EKG on June 3rd. Okay, obviously we're very concerned about it because A, he's in what I would consider, and I personally am always talking about this, new onset atrial fibrillation. For me, it's like VTAC. Seriously, like you are not going to stay in new onset atrial fibrillation if you're under my care and I have anything to do with it. Sometimes people agree with me and other times they don't. But new onset AFib is a profound exacerbation of cardiogenic shock and ventricular volume overload. So really, really important to get that patient out of AFib as quickly as possible. And of course, we all know how to do that. Everybody does it every day. But if you're unstable, obviously, we're going to cardiovert you, but we're going to work aggressively to get you out of AFib. And that's the beauty of agents like amiodarone. They give us some possibility for that. But if patients refractory to amiodarone, I'm going to remind you that this is also a sympathetic overdrive dysrhythmia. So thinking about quick on, quick off beta block may be very helpful, and it takes nerves of steel. Normally I'd say buns of steel or something else. But here's the thing, it does take nerves and buns of steel because your patient is just on the edge of being unstable. And now you're talking about a beta block, right? And everybody is nervous. Okay, I appreciate that, but I've got alpha stimulation. So if I need an alpha stimulant, in this case, I might choose the epinephrine. Normally in cardiology, I would never use the epinephrine, but if I feel like this is sympathetic overdrive, I need to lyse the stimulation to the myocardium and to the pacemaker pathway. So I have to balance those two things and be prepared. So whenever I ask for things, mostly I just go to pharmacists and I say, this is what I think and this is what I want, and they say, okay. I'll just check with the team. And they check with the team. The team always always says yes to the almost always says yes to the pharmacist. They don't always say yes to me. So I just learned how to deal with it. They say yes to me a fair amount, but not always. So, and it also depends on if you're a new attendee. You don't know me. But you're gonna know me after this. Okay. So, is this RV failure? Okay. So let's take a look early on at patient CVP. CVP is 24, 25. Is it RV failure? Yes. We think it's RV failure. I mean, it could be RV failure and mediating RV failure, but I've definitely got RV failure now. So we did some diuresis. You can see that that assisted a bit. We also thought, we didn't think about really beta block on the patient because he wasn't particularly tachycardic. But look at how much Lasix he got. He got 40 times 1 on 6.3, then 120 times 1 on 6.3, then 140 times 1 on 6.4, 140 times 1 on 6.5, 140 times 1 on 6.6. And his CVP ultimately dropped. Well, that was a good sign, because if I give you Lasix and you make urine and your CVP comes down because you no longer have profound venous stasis, the problem is that he started with venous stasis because he had RV dysfunction. So now I've made him functionally and profoundly hypovolemic, and he did have a cardiac arrest. I didn't make him. No. Somebody else did. I'm not saying it was right or wrong. It just was pretty darn aggressive. Okay. So I want to remind you about CVP. CVP is really, really, really important. It's always important to remember that when CVP goes up, the first consideration should be RV dysfunction. RV dysfunction as a primary event, RV dysfunction as a I missed my word right now, a synchronous or a conjugal event to the left ventricle. Conjugal, that sounds good. Okay. Do you like that? So very, very important when we're thinking about that CVP to remind ourselves that it's really hard to achieve total body volume overload. What we typically see is venal and interstitial volume overload with arterial volume underload. And that's really the consequence here. When I talk about hypervolemia, you're making a lot of urine, you have a good systolic pressure, you have a good EF, and you have a high CVP. That's volume overload. You know how much volume I have to give you to make your volume overloaded, both venous and arterial? Like 20 liters. But I gave you 2 liters because your CVP went up, but your blood pressure didn't respond. That's an indication of primary RV dysfunction and cardiogenic shock. So high CVP with a low MAP indicates that your right ventricle cannot generate forward flow. That's really important. High CVP, low MAP. Okay? And as your CVP trends upwards, typically that indicates worsening RV performance. So the thing is, CVP is great, POCUS is great, but you really need an echo. Echo is the gold standard for evaluation of the heart, and we really want an echo. And like, okay, you're coming upstairs, you're doing maybe you're doing a POCUS, and you're like, I can't visualize the RV. Okay, I need echo. And when the echo tech comes, you say, I have to see the RV. Because they'll basically, the problem is now it's really hard to visualize the RV. Oh no, we're going to continue here until we can see the RV. We've got to see the RV. Typically what you see in these kinds of patients who have RV-generated cardiogenic shock is the LV is relatively empty. If the LV is empty and your CVP is up and your neck veins are distended, you've got RV failure. I mean, there's no other explanation. LV is empty, CVP is up, interstitial volume load, gain in weight, bilateral edema. Okay, guys, you got volume, wrong place. And typically when especially my trauma surgeons say, oh, the LV is empty, give more volume. We give more volume, you get worse. Right? I mean, we just have to think about our critical analysis here. So bedside clues in cardiogenic shock. Well, this is not all there is, but this is typically what we look at. RV under stress because of the LV, RV under stress because it's primary, it doesn't matter. You have a rising JVP, a rising CVP, you have a drop in blood pressure, you fail to respond to diuretics, and you need inotropic support. These are really good clues of cardiogenic shock. Really great clues. Like, most of the time we give Lasix, we give more Lasix, we give more Lasix, we give more Lasix. Patients don't make any urine. What do? We hang Lasix through. That's like, so, I'm gonna put mouths in the words of my nephrologist, or the other way around. Words in the mouths of my nephrologist. Because this is not really what they would say. But what I would say is, just like titrating up on norepinephrine with no response. Why are you titrating up on Lasix with no response? If your patient isn't responding, you have to have some concern. You have to have blood flow to the kidney to respond to Lasix. You have to have blood flow to the kidney to actually communicate renin to the liver for conversion to ultimately to angiotensin II. If you don't have blood flow to the kidney, your renin goes up, but your angiotensin II goes down. That's really important. That's a really important thing. Once you have reduced blood flow to the kidney, you're going to have failure of many, many events. And by the way, one of the easiest things I can look at is GFR. I love GFR so much. I can't believe how much I enjoy it. Okay, so take a look at your patient. I want you to look at the top under the PO2 venous. 25, 32, 30, 28, 29, 31, 32. Okay, so remember, if you are less than 30, you have poor blood flow. He has poor blood flow. He's in shock, and he stays in shock for a fairly long time. And then what we also see as we look here is our patient's BUN going up. Creatinine stays relatively stable. It does increase by what's required in the first 48 hours of care. If your creatinine increases 0.3 milligrams per deciliter in the first 48 hours of care, you have an AKI. Doesn't mean you need to call for dialysis. It means you need to resuscitate your kidney. And your GFR, greater than 90, Yahoo, 70. 77. And then greater than 90, Yahoo. A good way for us to look at our resuscitation. So I don't have a watch on.
We have 20 minutes.
I have what?
20 minutes.
What? Fantastic! Oh, I'm so happy. Thank you. There's a clock right here. I couldn't look. But I think I started late, so you gave me some extra stuff and stuff.
25.
Okay, good. That's okay with me. Okay, and then I want to just take a look here. Okay, so if you're not used to calculating SPR, SPR is a calculation that is mean arterial pressure minus CVP divided by the cardiac output, and then that sum times 8. Okay, no one cares. You don't need to write that down or worry about it. Okay, but MAP minus CVP. So that tells us how the heart is working to overcome the gradient of pressure to ultimately land volume back in the right ventricle. That's what it is. And one of the ways it does that is based on the resistance of the artery. So it's a calculation, MAP minus CVP divided by cardiac output, that's on product times 8. Or if you used index, that's fine. Okay. I always have to have a positive vascular resistance. If I have a negative vascular resistance, I'm either on Mars without my suit, or I'm dead. Okay. So, I want you to notice here, when you look at your CVP up here, here's the problem with point click and verifying without actually verifying. CVP, 262. Okay, if I had a CVP 262, I would have exploded. It's impossible, physiologically impossible. Completely physiologically impossible. But, point click, verify, not looking at it. What happened is, of course, that she was infusing and turned off to monitoring and infusing, and Epic grabbed the number, which was 262, looking at the pressure from the pump, right? And so what she did was she didn't turn off the transducer. She turned her stop clock down. So here is the fluid going into the patient. Here is the pressure tubing as a transducer. She turned the stop clock down, which is completely, from my point of view, verboten. That means forbidden. I think I didn't say it very well. Verboten. Forbidden. Don't do that. Because then I had to grab that number and then she didn't verify it. She pointed and clicked, and now in the chart for all time, the patient has an SVR of minus 2,969. Okay, like, is this the screenplay for Dumb and Dumber and Dumbest? What is that telling you? Nothing about being smart enough, but that we weren't being careful. I should probably have said it that way. I don't wanna say, I'm not insulting, I'll be flippant, and I don't mean to be flippant. It was like, okay, your patient is really sick, and you're really busy, but you verified numbers that were incorrect, and then that puts the number in there. And I'm gonna tell you, I've had 3 expert witness calls about SVRs that were negative 1,000 or more. And I already know exactly what it is. Like, the nurse turned the stopcock down and was monitoring the pressure of the pump and not the patient. So I say that's not negligence, it's just, they just forgot to verify it correctly. It's okay, it didn't harm the patient. Patient isn't harmed, they didn't only have a CVP of 260. I did have one lawyer say, isn't a CVP of 262 extraordinarily high? How could the patient tolerate it? No. Patients can't tolerate it, they would have exploded under our care. Okay, alright, so here's our CAP report on our patient now, right? He's on norepinephrine, he's on dobutamine, he has a cardiac index that is very low, both by FIG calculation and by thermal dilution. And his LVEDP is 30, wedge pressure is 30, PA pressure 63 over 30, normal PA pressure 20 to 30 over 8 to 15, very high pulmonary artery pressure. When the pulmonary artery pressure is high, that then affects your right ventricle. And remember, the right ventricle has already had an infarct in the inferior and posterior surfaces, both of the left ventricle and the right ventricle. And right atrial pressure now is 22. So your patient has left ventricular failure and right ventricular failure and cardiogenic shock. Okay, so I want to bring that to classic and modern. Classic signs of cardiogenic shock. SVP less than 90 or greater than 30 minutes. Systolic pressure, we're not talking about me. Systolic pressure. Okay. The skin is cold and clammy. The patient is polyuric to anuric, and they have an altered medication. Now that's just classic signs for anybody to apply. We can add into that the measure of your cardiac index less than 2. Cardiac index less than 2 is really important here. But modern, there is actually a Society for Coronary Angiography and Interventionalists actually give us a new shock stage classification, which is very simple. We're going to look at it. Lactates greater than 2 and dynamic echo markers. So this is our modern definition of cardiogenic shock. We can look at our subjective evaluations. We can look at objective parameters, but true cardiogenic shock, honestly, it's going to be lactate, pulse pressure, and echocardiogram. And that's what's going to help us to advocate for our patient. And what we want to be able to do is we want to be able to diagnose patients early, and they are still compensated before they decompensate and are hypotensive. Because once they decompensate, it's much harder to pull those patients back. So the SCAI shock classification stages A through E, okay? Large MI, no hypoperfusion, so your lactate might be mildly elevated, it might be at 1.9, could be 2.1, but it's not significant. But you're on your presentation, we know that you're at risk for cardiogenic shock. We do your first lactate. You are not responding, your GFR is not improving, you're not making urine, your neck veins are distending. I'm going to do another lactate. As the lactate, the second lactate might show that the lactate now is starting to rise, and you now may have some mild hypotension. That's stage B. Stage B, rising lactate, normal or mild hypotension is where you want to intervene. That's where we need to intervene. And this is going to be more precise than waiting for CVP to go up. Okay? And I love CVP, but this is more precise. Stage C, you are now decompensating. You're hypotensive, you're hypoperfused, your lactate is elevated greatly. So remember, we're looking just like in sepsis. We're talking about initially when we talk about lactate sepsis, it's greater than 4, and then we change that to greater than 2. So now I'm going to say with cardiogenic shock, 1.5 to 2.5 puts you in stage B. 1.5 to 2.5 puts you in stage B. And then stage D, you're deteriorating, you're adding vasopressors, but the patient is getting worse, acidosis is worse, rising, and then stage E extremis, refractory shock, impending cardiac arrest, or ongoing CPR. Either, CPR with mechanical circulatory support methodologies or actual CPR. Okay, so just looking at that classification, thinking about the bottom, A, which is at risk, right? You're not hypotensive. You might be mildly tachycardic, but you are at risk because we know you had a large MI, et cetera. I'm going to get in there. And then the next step, okay? So now you've got tachycardia, you may have mild hypotension, and just a slight elevation in lactic acid, and it may not be a significant metabolic acidosis. Your base, which is normally 0 plus or minus 2, might be minus 3 or minus 4. Usually no cause for alarm. Usually we're not worried about that patient. But we've got these early signs in this beginning stage. So basically you're looking at this. This is from Sky. I didn't develop this table, and it's a lot of information. But just I want to think about level B. So level B, there's some clinical evidence of hemodynamic instability, right? Your neck veins might start to elevate. You may still be perfusing. You may still have good visceral pulses. Your lactate might be normal or just starting to rise. You might have some minimal acute kidney injury, and what I'm going to say here, an increase in creatinine of 0.3 milligrams per deciliter and a reduction in GFR. That's going to be one of the most important signs of stage B cardiogenic shock. Creatinine, 0.3 milligrams per deciliter, minor, right? And a reduction in GFR. We're going to marry those two things together. And typically the BNP is going to be mildly elevated. But your systolic pressure typically is going to be okay. It may have dropped to 90, it might be a little bit less than 90, your MAP might be a little low, and your heart rate may be a little bit elevated. But remember, I focused on your lactate, I focused on your creatinine, I focused on your GFR. If your lactate now increases aggressively, you've moved out of stage B. And now it's going to be much harder for us to resuscitate those patients. So we want to pay a lot of attention to what the claim. Creatinine now is 1.5 times baseline, not just 0.3. 1.5 times baseline. GFR has dropped more than 50%. That puts me in stage C. Right? Now, that patient stage C now is requiring pharmacologic or mechanical intervention to maintain their blood pressure and their blood flow. They have some alteration in their mental status. They have other alterations in their hemodynamic measures. Remember, once you hit stage C, now this is a race to prevent death. Stage B is where we should all be evaluating patients to be proactive in order to do the right thing. So we want to recognize these patients early. Early warning signs before collapse, narrowing pulse pressure, and a rising lactate. Okay, that doesn't mean your lactate is 3, it doesn't mean your lactate is 4. It means your lactate is greater than 1.5. It's not going to be greater than 2.5 because then you're going to be in stage C. Stage B, greater than 1.5. Okay, and you are starting to see some venous congestion. The lungs are getting a little bit, red. You see it on chest X-ray. You can see it in your need for some oxygen support, your shortness of breath, and your CVP or your JVD is increasing dramatically. Okay. Always important, if possible, if you're at the bedside, is to try to differentiate, and you're doing that objectively and objectively and subjectively, right? Are my lungs wet? Are my neck veins wet? Distended. Lungs wet, neck veins distended, biventricular. Neck veins distended, but lungs are dry. I'm going to say that's right ventricular. And that's going to be really important. And honestly, that just gives rise to the request and the response for an echocardiogram. I need an echo. Focus is nice, not good enough. I need an echo. Okay? If it takes, like for us in our emergency room, we have 1,000 patients. We see 500 patients now a day in our emergency department. We have clinics. These are not people coming in for a bug bite. They're coming in, they walk in with a potassium of 1.5. patients who have come from a culture of poverty and a culture of failure of primary health care who come in and they're already so critical when they come in. Not every patient in ECC is critical, but it's not like, I came in for a bug bite or my daughter has a little cough. That's not what they come to the emergency room for. Because first of all, they know they're going to be waiting 6 to 10 hours, so they don't come there for a little cough. They come for something really urgent. Here's what I'm reminding you about this, is that as we are evaluating our patients, we really have to actually try to differentiate as best we can. Is this biventricular failure? Is it early LV failure, or later LV failure will always cause RV failure? Or is it early RV failure? Because we're going to treat those failures and that cardiogenic shock differently. And my request is always for POCUS. In our emergency room, you can wait 36 hours for an echo. So we do POCUS early on. We use POCUS, point of care ultrasound. We look at pipes, not veins. We look at pump, septal wall movement. That's really the thing we can visualize best with POCUS. And if there's ventricular wall abnormalities, you can't always isolate what they are, but that's what we use POCUS for. And then we use it for pulmonary to look at whether or not there's infiltrate the pearly B lines in that evaluation. It's fantastic. It's also kind of primitive. But it's easy if you've got a good ultrasonographer, your APP or your physician, that they're good at it. We're going to be able to glean a lot of information, and that's really quick. We don't have to wait for anybody. We don't have to meet any insurance criteria or whatever else. We're just going to do a POCUS, and that's going to be our first step. So we do a lot of POCUS in our ECC, discover a lot of septal abnormality, neck vein distension, and pearly B lines. So that all tells us that we've got heart failure. Septal abnormality, distended neck veins, curly B lines, biventricular. Neck veins distended, septal abnormality, no curly V lines, right ventricle. Pretty straightforward. And that's how we're going to advocate, and that's how we're going to look at our patient. So I would say that the ACC and the AHA's strongest focus right now is about how do you differentiate right ventricular dysfunction from biventricular dysfunction. The age of the Cinderella stepchild right ventricle is over. Right ventricular dysfunction almost always missed and almost always. So really, really important. So again, I'm thinking about those early signs. Narrowing pulse pressure. Remember, normal pulse pressure should be 35, 30 to 40. If your pulse pressure is narrowed with tachycardia, that's going to be an early sign before collapse. Really important. The rising lactate, even before hypotension, really important. And then, of course, venous congestion. That is going to actually identify for us that we have a right ventricular shock. So this old adage is still here today. This is called the Forrester graphic, okay? Which is, are the extremities warm or cold? Are the lungs wet or dry? But now we're going to add into that, I'm going to add into it. Not only are the lungs wet or dry, but are the neck veins wet or dry? And we just look at a collapse of the neck vein to actually determine that, so we can do that with focus, right? So in the old Forrester graphic, we talk about your periphery is warm, and your lungs are either dry or you're wet. If you are wet, this is typically mixed shock or cardiogenic shock. Your lungs are wet, but your periphery is warm. You could have vasodilated shock or mixed shock. So you've got cardiogenic on top of the vasodilation. If you are warm and dry, that typically is an indicator of early vasodilation shock. So I don't have a lot of volume load in the lung. I don't have a lot of volume load in the central veins. I'm very warm on the extremities because I have vasodilation, but it's not cardiogenic shock. For you to have classic cardiogenic shock, you're going to have to be wet somewhere. Wet in the lung, wet in the neck vein, wet in both. Okay? Does that make sense? I got volume, I can't move it. So it stays in the lung, it stays in the neck vein, it goes in the interstitium. So typically for cardiogenic shock, we're going to expect that patients are a little bit wet. That's really one of the best differentiators. So I'm listening to your breath sounds, I'm looking at your chest x-ray, I'm looking at your neck veins, I'm seeing if they collapse, I'm CVP. That's gonna give me a lot of really great information. Your PVO2 less than 30, you're in shock. Now I go back and I look at your lungs and I look at your neck veins and I try to determine what kind of shock you're in, because that trajectory is gonna help with my intervention. That's gonna help me do the right thing. So there are some really particular testing clues that are require diagnostic, okay? So very first thing is looking at the IBC dynamics, are they compressible or not? Looking at lactate greater than 2, that's a primary marker of tissue hypoperfusion and disc metabolism. It is not a marker of sepsis, it's a marker of disc metabolism, okay? And more important than that, can you clear your lactate? So that says to me, first of all, if you've got an elevated lactate, I have to give a second one. I'm treating you. You've got an elevated lactate, I'm giving you volume, I'm giving you vasopressor, maybe I'm giving you inotrope. That next lactate should be either stable or going down. If that next lactate is going up, the therapy I'm applying to the patient isn't working. In sepsis, especially in early sepsis, you do volume resuscitation, we usually corner that lactate and it starts to come down. But in continuing elevated lactate, typically need cardiogenic shock on top of your original diagnosis. And mixed shock, remember, has a mortality of 75%. So that's going to be really important. The other issue is looking at troponins plus BNP plus pro-BNP, which is an earlier indicator of myocardial dysfunction. Now, there are some other emerging labs that are not available right now that are being studied, and that would be galactine-3 and ST2. We don't do any of that, but it does tell us about fibrosis and myocardial stress. And all of this actually helps us to determine whether I can do pharmacologic circulatory support. So pharmacologic circulatory support is typically inotrope plus dilation. Again, mechanical circulatory support can go from balloon pump to left side impella, to right side impella, to bi-impella, to VAD, and to ECMO. Okay, all that is mechanical support, right? And the decision that I make is really going to be based on where I think this study is, right? For me, balloon pump is great because it's available all over the place, but it's not really very effective. I really want you to have an impella, if I can. I don't place them, but I advocate for them a lot, and we do them a fair enough. We don't, at Grady, 1,000-bed hospital, public safety net, we don't do ECMO. And our patients are typically uninsured or underinsured. And so fighting for an ECMO bed in all of the hospitals that will say they're not for profit, but really, I mean, come on, Piedmont, Keystone, Emory. So please, please, please give me an ECMO bed. Is patient uninsured? They don't ever say that, but I think it's part of the factor. Because I would say out of 10 patients, we get one ECMO bed. Because we don't do it ourselves. So yes, we are progressing towards ECMO. It's a big thrust. Right? Can't wait for the day. We're going to start with feeding and move to VA. So very important to remember that if I have left ventricular failure, I'm going to need VA ECMO. If I have right ventricular failure, I can usually use VV ECMO. If necessary, I can do VA ECMO. And so again, looking at ECMO, ECMO beds they're not sparse, but they're not highly available either. And then, of course, thinking about that PVA-CO2 difference. This is what's being promoted now. The CO2 in the arterial bed, normally 35 to 45. The CO2 in the venous bed, normally, I think I said earlier 45 to 55, but it's normally 40 to 50. 40 to 50. PVCO2, 40, 35 to 45 arterial. Sorry, my mind is crazy. You see, that is not enough coffee. Okay, 35 to 45 in the arterial bed, 40 to 50 in the venous bed. That's normal. So the gradient between them can go up to 10. The difference. PV minus ACO2, gradient greater than 10, indicates failure of cardiac output, failure of perfusion. Okay, even if it's septic shock, it's a failure of cardiac output. You're not delivering enough blood flow. So now we're going to take a look at that. And we're going to use that as one of our early tools. And then, of course, doing cardiac ultrasound, which is a focus rather than a focus. It's a focused cardiac ultrasound or echocardiogram, and it is absolutely central to the diagnosis. So I've got a septic shock patient who's not responding the way I think, and I'm titrating up on them. They need an echo. They need a focused cardiac ultrasound, and they need it right now. And remember that cardiac dysfunction is why patients die in sepsis. They have mixed shock. So they have septic shock and cardiogenic shock, even if they have great works before they came to us. Now, the demand on the myocardium has been high. We've got some alteration in supply demand, oxygen to the myocardium. Their myocardium has become dysfunctional. Inflammatory mediators cause cardiac dysfunction, and that's really significant. So just really quickly talk about BNP or NT-proBNP and troponin. Nobody's doing a division or anything else. All we are going to remind ourselves is that BNP, beta natriuretic peptide hormone, or the pre-hormone, which is what we call NT or N-terminal, pro-BNP. So it's just BNP, the absolute hormone, and the pre-hormone, which is the pro-TBNP, that actually tells us very significantly about cardiac dysfunction. BNP has a short half-life. BNP is, of course, released when there's a lot of volume in the atria and there's a volume overload because we're not able to mobilize our blood flow. But what's really important is BNP has a short half-life. So your patient may be fooling you because their BNP doesn't look so severe, but the pro-BNP stays elevated longer. And so it just gives us an additional piece of information. Your lab already does this. You just have to ask for it. They can do it with their standardized laboratory equipment. And what's really important is that BNP just naturally degrades in the blood, but pro-BNP requires renal excretion. So if my pro-BNP is going up, I've got myocardial stress, but I also have reduced kidney function, which is a very significant symptom that tells us about failure of the heart, okay? So really, really important. BNP and pro-BNP reflect strain, and troponin reflects injury, and that signals a severe cardiac dysfunction. So just ranges for both, okay? Normal BNP, less than 100, and pro-BNP has a little bit of a different level, less than 125 if you're under 75 years of age, and then less than 450 if you're over 75. So it's got a different leveling because it's more specific, and it's a higher level because it's a pro or a pre-hormone. So that's a really important perspective. Hopefully in your cardiac program, you've got cardiologists who are looking at this and paying attention to the new guidelines. And then I just want to remind you about lactate and lactate clearance. So lactate clearance is the patient's initial lactate minus the subsequent lactate, and divided by the initial lactate times 100. Okay. Now, your lab is not sending you lactate clearance. My lab doesn't. So it does mean you have to know this. Initial lactate minus subsequent lactate divided by initial lactate times 100. Okay. And that gives you a percent value. And what you want to see is if you are clearing lactate at 20% or greater, things are improving. If you are not clearing your lactate, then things are getting worse. Okay, so it's not just saying first lactate looks bad, the second lactate looks the same or worse. It's actually about, are you clearing lactate? For you to clear lactate, you have to have good blood flow. You have to have good renal blood flow, you have to have good liver blood flow, and you have to have good distal blood flow. So this is a really, 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 really important, okay, perspective in terms of how we're looking at our patients. So poor clearance, so lactate clearance rate of less than 10% over 6 hours is associated with poor outcomes. And my whole goal, right, I'm saying I'm looking at GFR, I'm looking at pulse pressure, I'm looking at BNP and pro-BNP, and I'm looking at lactate clearance, because the days, my friends, of being a critical care nurse who is just titrating up on vasopressors to an MAP, those days need to be over. They need to have a very nice funeral with a really good headstone. Goodbye, MAP resuscitation, I got better values now, right? That's like, you know, when you're 90 years old and your spouse dies, you say, hey, I'm looking for a 30-year-old man. I got better. So, really, really important for us to appreciate. So, last and not least, that's just number one clinical case, 68-year-old man presents to ED. He's got an acute onset of chest pain, shortness of breath, altered mental status, we're already worried about him. Blood pressure is 80 over 40, heart rate is 120. So his pulse pressure is 40, he's tachycardic, and he has cold mild extremities, and his lactate level is 7.2. Well, okay. We don't need too many other things to know that, but when we look at the patient, he has EKG changes, we say he's got acute myocardial infarction, and he is presenting in cardiogenic shock. So here's his EKG. Okay, nobody is surprised to say your patient is having an acute anterolateral myocardial infarction with reciprocal changes in the inferior wall. Okay, and then we think about, we took a focus to him before even X-ray could get there, and looking at what this is, when we talk about curly bee lines, I always used to think that meant C-U-R-L-Y, and I was looking for things that were curly. You know, curly is the name of the physician who identified this. Okay, because when physicians identify something, they get a name. Okay, and what it is vascular engorgement. And usually the lines are on a vertical perspective to the diaphragm. So you kind of see those engorgement lines, those are known as curly bee lines. Those are really highly indicative for heart failure, okay? So immediate interventions for this patient, intubation, mechanical ventilation, initiate on norepinephrine infusion, and then an intra-auricular puff was placed for this patient. And the serial lactate monitoring, which was really, really important. So now we're putting that into perspective. First lactate 7.2, 6 hours later, lactate is 6.1. So remember that 7.2 minus 6.1 divided by 7.2 times 100, and that was 15%. Now, I want it at 20% or greater. I'm still concerned because it's 15%. If it was less than 10%, it would be really disturbing. But as we're stabilizing the patient, you would already know he's doing better. His lactate is down to 4.8, but the clearance rate is now 33%. And then 24 hours later, because remember you're looking at that initial lactate, over that 24-hour period, you have cleared 75% of your abnormal lactate. That means you did right. You did great. You went on norepinephrine, you went on balloon pump, you did great. You're heading in the right direction and you're almost there. You're almost there. Okay, second case, 72-year-old female with history of hypertension, type 2 diabetes, chronic kidney disease, presents to the ED with very severe shortness of breath, very significant fatigue and chest discomfort, blood pressure 85 over 50, so we've got a narrow pulse pressure, heart rate 110, respiratory 28, oh, we're really worried about her, and her sats are 88%. And when we look at her, her extremities are cold and mild, her jugular veins are distended, we look at a CVP, it's around 19, and she has bilateral tractus on lung auscultation. Her EKG shows ST segment elevations in the anterolateral wall, and again, based on that presentation, we diagnosed cardiogenic shock. So this is her EKG, anterolateral, right? So she's got ST segment elevation 1 in L, and in actually from V1 all the way to V5, she's got ST segment elevation. And this is her chest X-ray. And you can see she's got the presence of curly bee lines and a great big old heart. You don't have to be radiologists to say, woo, that heart looks big. Okay, so I want to apply each one of the things that I mentioned. Okay, so in her biomarker result, her troponin, cardiac troponin was 10.5 nanograms per mil. So in HS troponin, 1,000 times standard troponin, 10,500. The upper limit of normal for standard troponin is 0.04, and for HS troponin, for females, I'm sorry, I mistyped that, is 15, and 20 is for men. Okay, so that confirms that she has myocardial injury. Her NT-proBNP is 8,500. Okay, now she's under 75, so remember, 175 or greater, she's at 8,500. Okay, so 125, sorry. Okay, so very significant stress, very significant LV dysfunction. Lactate is 5.8, indicating tissue perfusion, hypoperfusion. Creatinine is 2.1. Now that, we are going to say, well, she's got CKD, so you can't really use your creatinine here. Take a look at her GFR, 15. Right, does she have good renal flow? Yes or no? Yes or no? If the GFR is 15, no, right? She has an elevated creatinine, but she has pre-existing kidney uric or anuric at home, she's not on dialysis. So we would expect her to increase her GFR when we resuscitate her. And now you've got all these things that you're bringing together. Now, in these cases, they are really obviously in cardiogenic shock, and that's what's really fantastic. But many patients are not obviously in cardiogenic shock. So looking at these strategies, thinking about their pulse pressure, thinking about the lactate and lactate clearance, thinking about BNP and pro-BNP plus troponin, help us to actually, very frequently, shift our trajectory from pure sepsis or pure hypovolemia to incorporate the presence of cardiogenic shock. And these are the new ways that we talk about today, thinking about our patients in cardiogenic shock. So she gets IV fluid, oxygen supplementation, inotropic support with dobutamine, and then what I want you to see here is her lactate clearance. So 6 hours post PCI, after her PCI, 28% clearance, good. 12 hours, 57% clearance, good. I can then say, even though I put her on, needed some vasopressor, my inotropics and my fluids have worked for her. If I put somebody on vasopressor and their lactate clearance is less than 10%, I'm not doing the right thing. I'm not doing the right thing. So it gives us a much broader view to evaluate our patients very well. So again, kind of thinking about all the different things that we look at, she eventually stabilizes. She gets weaned off the vent. She has a long stay in the hospital. We optimize her outpatient medical therapy for heart failure and try to put into play therapeutic regimens that are going to help protect her from a secondary admission for cardiac death. So I do just want to mention one last thing, and that is, why do we measure PV minus CO2? Very, very validated today. Now, the literature will say greater than 6 to 8, but we have a lot of patients that have a gap of about 8. So in our practice, we say, in our hospital practice, we say greater than 10. Looking at that gap as a very wonderful way for us to evaluate that you have poor cardiac function. And it guides your resuscitation efforts. So you're getting blood gases anyway. Get an arterial gas and venous gas drawn at the same time. Look at the PVA CO2 difference. CO2 is the respiratory acid produced at the cell in metabolism. That's all it is. That's, the lungs clear it, but it's production at the cell. And when the cell is anaerobically producing, it's going to produce more CO2. So if PbCO2 is up and PaCO2 is less than 10 away, your problem is not production. The problem is probably clearance. Okay? PbCO2 is up and the gap is wider than 10 to arterial CO2. So let me just say, PbCO2 is 58, arterial CO2 is 40. That's a gap of 18. That is a production problem. And by the way, your patient's breathing deep and fast, and they're blowing off a lot of CO2. That's what you're measuring with CO2. Is how much CO2 you're blowing off. You're producing a lot of CO2, you got to blow off more. Okay. Once you lose compensation or re-intubate, you can control your respiratory rate. Now we really pose a problem. So again, this is going to be one of your best methods. One of your best to evaluate microcirculatory blood flow, which, by the way, is the only thing I care about. I don't care about MAP. I mean, I do, but I care about microcirculatory blood flow. So for us, in today's world, something simple we can do. Everybody has laboratory analysis that they can do. Everybody does blood gases. You do with iStat, you send it to your lab, it doesn't matter. Everybody who works in critical care has the ability to do blood tests. We don't all have OPS scanners where we can look at microcirculatory flow. This is the only way we currently have to look at microcirculatory flow. And by the way, in sepsis, I'm resuscitating the microcirculation. In any shock state, I need to know that I have achieved appropriate blood flow in the microcirculation. Is everybody you work with going to jump up and down and say, oh, thank God you went to a conference where they talked about this. I've been wanting to implement this forever. No. So if you want to reach out to me, I'll send you some literature references or some PDFs. You're welcome to do that so that I can give you good science. So the last patient, I just wanted to, we don't even have to go through anything. His PaCO2 was 40, his central venous PCO2 was 59, 59 minus 40, gap is 19. Do you have this blood flow, yes or no? And that's all there is. There's no other answer. You do not have good blood flow, period. That's it. That's the only answer. When you have a white gout, you don't have good microcirculatory blood flow. So we add that to lactate clearance. We add that to our BNP and our pro-BNP. We add that to pulse pressure, to systolic pressure, to distal extremity capillary refill time. We have a fantastic, beautiful, forward-thinking package to help us evaluate our patients, to be proactive when we see low-level failure of microcirculatory blood flow, narrowing pulse pressure, and mild lactate increase correlate that to your GFR. You got a picture of shock. Bring that now to the lung and the neck vein. You got a picture of cardiogenic. Doesn't matter that you came in with sepsis. You got cardiogenic shock. And we can really make a difference in the mortality for our patients, the morbidity for our patients, and their return perspectives over time. So really, really, really significant and important. And that's what really brings us to our best possible method. So I'm just going to do a quick summary. Follow the clues. So everything that we've talked about in terms of our clues, follow those clues. Think about focused ultrasound, think about bedside evaluation, look at the sky interpretations and apply that. Narrowing pulse pressure, rising lactate, increased venous congestion. How we look at that. Thinking about our echocardiogram. And then following those clues for us as bedside providers, as bedside nurses, what we're going to focus on. Capillary refill time, low urine output, low GFR, elevated lactate, just even mild elevation, troponin BNP, and lactate clearance. That's new for most of us. We're going to look for MAP trends. We're going to look for systolic pressure trends. We're going to look at whether or not I can actually measure a plaque. Not just saturation, but the plaque. And how that's going to help me to evaluate my patient better. So that's, did you get what you wanted?
No, I missed it. I was gonna do that. Thanks.
Okay, so here's the thing, follow the clues. Always be a detective because you can be proactive if you're a great detective. And that's the thing. And recognize that despite the fact that we've been looking at cardiology and CC care since 1960, things are moving fast in the diagnosis of cardiogenic shock. They're really changing. And so we want to be open to the change and we want to apply it as best we can at the bedside. Thank you very much, everyone. I'm going to put my phone number and my email up.
All right. I was gonna say, while she's pulling it up, a couple of housekeeping things that I did not mention earlier. So everybody should have received a white goodie bag when you first came in and you registered. That is courtesy of Cookville Regional. There's, I think, a pen and a notepad, maybe a bookmark, couple things in that. You should have a folder in there also that has, inside the folder is an evaluation. Each speaker in each session will have an evaluation. Please fill that out. We want your feedback. Your feedback from today, good, bad, or ugly, is going to help us do better next year when we have this symposium. If you need more snacks, let us know you need more snacks. If you want more time, I want this to be 2 days, let us know that too. If you're like, you know what, there was not enough coffee, I needed more coffee in my life, tell me that we need more coffee.